Before coming to the clinical uses of tetracyclines, let us discuss the clinical use of glycyl cycline derivative tigecycline. Because in the previous slide, I have mentioned that tigecycline has a half-life of 36 hours. It's a derivative of minocycline, has a wider antimicrobial effect, and its clinical uses in comparison to older tetracyclines is much superior. The organisms sensitive to it include coagulase negative staphylococci, Staph aureus including MRSA, vancomycin resistant strains, streptococci, both penicillin sensitive and resistant strains. It is also effective on Enterobacter, multi-drug resistant strains of Acinetobacter, anaerobes. However, it is not effective against Pseudomonas, Proteus and Gonococcus. Tigecycline is commonly used in treatment of skin and skin structure infections and intra-abdominal infections like appendicitis with perforation, diverticulitis and cholecystitis with perforation. So, all in the complicated cases where most of the other antibiotics are either resistant or not successful in treating the patients. It is used in combination with colistin to treat serious infections with multi-drug resistant gram-negative organisms. It is one of the most effective drugs to treat community acquired pneumonia. It is also found to be effective in donovanosis, also called granuloma inguinale, caused by Klebsiella granulomatosis. Though azithromycin is the drug of choice in this condition. Now, in this slide, you see the clinical uses of different uses of tetracycline. It starts with its action on mycoplasma. So, mycoplasma pneumoniae causing pneumonia and other respiratory tract infections are sensitive to tetracyclines, and there is rapid relief from fever, cough, fatigue and pulmonary rales with reversal of different radiological findings. Trachoma is commonly caused by Chlamydia trachomatis. It's responded well to tetracycline therapy, but doxycycline is always preferred because of its advantages over tetracycline. Trachoma are both inclusion conjunctivitis and simple trachoma can be treated with this. In sexually transmitted diseases, tetracyclines are extremely useful, especially in treating lymphogranuloma venereum, granuloma inguinale, urethral, endocervical or rectal infections caused by Chlamydia trachomatis. In the psittacosis, doxycycline is very useful in the treatment. Tetracyclines are also useful against Chlamydia pneumoniae. Tetracyclines in combination with rifampicin and streptomycin are effective in acute and chronic infection caused by Brucella melitensis, that means brucellosis. The regimen consists of a dose of around 200 mg of doxycycline and 600 to 900 mg of rifampicin per day for 6 weeks. In tularemia, this is probably your drug of choice, and mostly the doxycycline is preferred over tetracycline. Even in cholera, you can prescribe doxycycline rather than tetracycline, but tetracycline also can be prescribed both as prophylaxis as well as in the treatment. In the plague caused by Yersinia pestis, tetracyclines are effective as streptomycin in treating that condition. In amoebiasis, doxycycline and minocycline are both useful. Doxycycline is also used in the treatment of malaria with quinine, as well as it can be useful as a prophylaxis in case of a person who is traveling probably in an endemic area, and that area is probably containing strains which are resistant to chloroquine or sulfadoxine and pyrimethamine. In case of meningitis, and treatment of asymptomatic carriers by Neisseria meningitidis, to eliminate meningococcal from the nasopharynx, it is given at a dose of 100 mg every 12 hourly, though rifampicin is preferred for this kind of eradication procedure. In case of acne, normally loading dose of doxycycline 100 mg twice daily, started on the first day and followed by single dose 100 mg for at least 1 month. Because acne is caused by a different reason, but it can be associated with propionobacteria, that is Propionobacterium acne, and it is also useful to treat acne rosacea. In case of H. pylori infection, tetracyclines are effective, especially in quadruple therapy, where the triple therapy of clarithromycin, omeprazole and metronidazole or amoxicillin combination are failing. So, in quadruple therapy, it can be combined with the other drugs. So, next one please. Allergy skin rashes are very common with the topical applications of this kind of agents. It causes severe allergic reactions. Photosensitivity is commonly seen with demiclocycline, which is intermediately acting preparation, but it is not used nowadays except in case of diabetes insipidus. As an antibacterial drug, the role of demiclocycline is nowadays questionable because of its adverse effect. But minocycline may also cause phototoxicity, so one must be very careful while prescribing minocycline-like drugs. The third one is probably one of the most important adverse drug reactions of tetracycline group of preparations. Superinfection is basically termed as the suppression of the normal intestinal flora with resultant opportunistic infection, and is liable to occur after prolonged tetracycline therapy. Particularly, it's happened in patients with diabetes mellitus, leukemia or leukopenia, and those patients was getting corticosteroids are also susceptible to this kind of infection. Infection with Candida albicans is especially common and may cause diarrhea or soft, bulky, odorless stools, soreness, redness of the mouth, glossitis, black hairy tongue, and inflammatory lesions of the vulva, vagina, and perianal region, causing pruritus. Superinfections with resistant Staph aureus occur more frequently in hospitalized patients. Serious staphylococcal enteritis cause sudden loss of appetite, abdominal discomfort, distension, profuse watery diarrhea, and stools show the presence of blood. It carries a mortality rate of 40%. Pseudomembranous enterocolitis is characterized by profuse diarrhea and fever, may occur due to superinfection with Clostridium difficile. The stools contain shreds of mucous membrane and blood. These kind of problem can be treated with metronidazole like drug, and if superinfection is resistant to metronidazole, then vancomycin is probably used to tackle the situation. Now, why tetracycline is not given in case of pregnancy? and in children. Tetracycline chelate calcium and magnesium, but as it's having a chelating property on the calcium, it forming a tetracycline orthophosphate complex and are deposited in areas of calcification in bones and teeth. Now, administration of these antibiotics to pregnant women may lead to yellow staining of the teeth of the infant, defective formation of enamel, hypoplasia of the teeth, and pigmentation in the dentine region. Pigmentation of permanent teeth and increased risk of caries may occur also in children. Even a short course given after the 14th week of pregnancy can be damaging. Now, tetracyclines administered during pregnancy are deposited in fetal bones and may reduce their linear growth. They should also be avoided in infants and in children up to the age of 12 years. They are also deposited in nails, which may cause nails to fluoresce. Now, the same drug, if it is given in pregnancy, may lead to fatal hepatotoxicity. It has its hepatotoxic effect. It causes fatal hepatic dysfunction with pancreatitis. It may occur in patients receiving large doses of tetracycline over short periods, particularly via intravenous route. These patients normally develop jaundice, azotemia, and coma, but it is more common in pregnancy. And if any other hepatotoxic drug is given at the same time to the patient. It has this destructive effect on kidney. In patients with significant renal impairment, tetracyclines may cause an aggravation of azotemia and exacerbated anti-anabolic effect. A reversible Fanconi-like syndrome, which is characterized by nausea, vomiting, proteinuria, glycosuria, acidosis, and amino aciduria, may develop after ingestion of outdated tetracycline capsules, which is not common nowadays. It is attributed to a degradation product that is called epi-anhydrotetracycline, which is responsible for causing this. The formation of this toxic product is promoted by warmth, moisture, and an acidic pH with change of color from yellow to brown. Benign intracranial hypertension may develop in some patients, and it is called pseudotumor cerebri. This causes bulging of the anterior frontanelli in infants and headache, photophobia, and papilledema in adults. Next one, please. Few of the common drug interactions which we observe with tetracyclines are normally seen when a clinician may prescribe penicillin with tetracyclines. Now, in that case, penicillin is basically acting on the rapidly multiplying organism, whereas tetracycline is preventing the growth of microorganism. What will happen? Tetracycline will prevent the growth, and hence penicillin will not get rapidly multiplying organism for its action. So, the combination is not going to be beneficial to the patient. You will only get the beneficial effect of tetracycline, but penicillin will add on its toxicity with tetracycline to the patients. So, this kind of combination should be avoided in clinical practice. One is cidal, that is penicillin, and the other one is static, that is tetracycline. There are some drugs which may chelate, having the chelation property, like uh, the tetracyclines, and if it is prescribed with antacids and iron preparations, we will see that tetracyclines chelate aluminum or calcium or the magnesium compounds or even the iron salts present in the iron preparations and producing insoluble chelate complex, and that will reduce absorption of tetracycline. Hence, the bacteriostatic effect of tetracycline will be minimized. This is another example of drug-drug interaction which is basically pharmacokinetic in nature and which is non-beneficial to the patients. Tetracycline ideally should not be prescribed in a patient who is taking oral contraceptive pills because it will reduce conjugate estrogen levels and that may lead to failure of oral contraception. The anticonvulsants like carbamazepine, phenytoin, barbiturates are all inducing agents and they used to reduce half-life of tetracycline and hence its beneficial effect on the patient. There are some drugs which will decrease bioavailability of tetracyclines and those drugs are divalent or trivalent cations like calcium, magnesium, zinc, aluminium, iron. Milk and milk products, vitamin, mineral products, antacids. So it's better to avoid these products with tetracycline. So what is the take-home message? The take-home message is tetracycline is a group of drugs which includes the long-acting preparations like doxycycline, minocycline, and tetracycline-like derivative that is glycylcycline, tigecycline. Doxycycline is a first-line drug in few cases like rickettsial pox, Rocky Mountain spotted fever, in some kind of primary atypical pneumonia due to mycoplasma pneumoniae, cholera, chlamydia trachomatis, and in case of acne vulgaris as antibiotic. There is another drug which is invented recently that is tigecycline, which is basically a glycylcycline, a derivative of minocycline, having a broader spectrum, structurally similar to other tetracyclines, but highly effective against methicillin-resistant Staph aureus, vancomycin-resistant Staphylococci, and vancomycin-resistant Enterococcus. Normally, the tigecycline is given intravenously. It has a T-half of 42 hours. About 80% is excreted unchanged via biliary route into the feces and 20% in urine. So in case of appendicitis with perforation, diverticulitis, so all complicated abdominal, intra-abdominal, intraperitoneal complications can be treated with tigecycline if those conditions, those bacteria responsible for causing that kind of infection are resistant to the commonly used antibiotics from the group of beta-lactams and which are also used to treat anaerobic infections like metronidazole. Tigecycline is well tolerated, and one of the most important adverse drug reaction of tetracycline is the superinfection, which can be dangerous if it is caused by this resistant strain of Staph aureus or Pseudomonas Clostridium difficile, and it is called Pseudomembranous Enterocolitis. So this Pseudomembranous Enterocolitis, if it is happened to a patient, it should be treated with metronidazole, and if it is resistant to metronidazole, it also can be treated further with vancomycin. These group of drugs should be avoided in pregnancy and in children. The reason behind this is in pregnancy it may cause fetal hepatotoxicity as well as it will affect the growth of teeth and bones in the fetus. In children, it will chelate calcium, forming a tetracycline orthophosphate complex and deposited in areas of calcification in bones and teeth. And this will not only lead to the prevention of growth of teeth, it will lead to defective formation of enamel, hypoplasia of the teeth, and problem in the development of long bones. And this thing may persist even if it is given after the 14th week of pregnancy. So that's a little bit about tetracycline and tigecycline, and in my next class I will discuss a little bit about the other broad spectrum antibiotic, chloramphenicol. Thank you.